Hi, good morning. Thank you for having us. Today, Dr. Srinivas and I will be talking about congenital CMV and hearing loss. We have no financial disclosures or conflicts of interest with the material in today's presentation. The objectives for today's talk will be to understand the epidemiology as well as the signs and symptoms of congenital CMV infection, including hearing outcomes, to examine evidence for CCMV testing and antiviral treatment, and to review the pros and cons of hearing-targeted CCMV screening relative to universal screening in asymptomatic newborns. We will be reviewing a few cases throughout the talk. The first case is you are an outpatient pediatric healthcare provider, and your first clinic patient is a 16-day-old term newborn male presenting for a weight check. The delivery and birth hospitalization were uncomplicated, aside from 2 failed newborn hearing screens. He has been referred to audiology. You recall an association between CMV infections and hearing loss. Which of the following is associated with hearing loss? A, postnatally acquired CMV infection. B, congenital CMV infection. C, both A and B, or D, none of the above. We will have you think through this case for about 10 seconds, and we'll review the answer in the next slide. Only congenital CMV infection is associated with hearing loss. We'll be reviewing CCMV and hearing loss more in depth in the next few slides. CMV disease caused by postnatally acquired infection is typically uncommon in full-term or healthy infants. Infants at risk for developing symptomatic postnatal CMV disease are going to be preterm infants less than 32 weeks, very low birth weight infants less than 1,500 grams, or those who are immunocompromised. CMV disease due to postnatally acquired infection can cause a severe viral sepsis syndrome that can cause a hepatitis, pneumonitis, and thrombocytopenia. However, it does not have the same risk for hearing loss as congenital CMV. Cytomegalovirus is a double-stranded DNA virus that is a member of the herpes virus family. It has no seasonal predilection, so there's no seasonal trend like we typically see with flu or RSV, and it can persist in white blood cell and tissue cells after a primary infection and intermittently sheds in urine, saliva, or genital secretions. Those who are healthy or immunocompetent typically will have no symptoms, or if they do have symptoms, might present with a flu or mono-like illness. Those who are immunocompromised, for example, transplant recipients, are at greatest risk of severe disease. CMV can be transmitted through horizontal transmission, through direct-to-direct person-to-person contact, through the exposure to bodily secretions, as well as through blood transfusion or organ transplantation. Studies have shown that a major risk factor is contact with the saliva or urine of young children ages 1 through 3. Young children can then transmit CMV to their parents or caregivers, including those who may be pregnant. Vertical transmission of CMV to an infant can occur either in utero, which is referred to as congenital infection, during birth, referred to as perinatal infection, or following birth is referred to as postnatal infection through the ingestion of CMV-positive breast milk. The prevalence of CMV for women of reproductive age is estimated to be 86% globally and between 25 to 81% in North America. In utero transmission of CMV can occur in pregnant individuals either during a primary or non-primary infection. A primary infection occurs when an individual who previously tested negative for CMV is exposed to CMV for the first time during the pregnancy. A non-primary infection occurs when an individual who has pre-existing antibodies to CMV either has reactivation of a latent virus or infection with a new strain. Both primary and non-primary infections can lead to congenital CMV disease. However, primary infection carries a higher risk of transmission of 40% to the infant as compared to non-primary maternal infections, which carry a risk of 0.5 to 2%. There are currently no universal CMV screening guidelines in the US, so pregnant individuals are not routinely tested for CMV unless there is specific concern during the pregnancy. The main thing that we can offer to families is education on how to prevent transmission, and that includes good hand hygiene as well as limiting contact with the saliva and urine of young children. There's also the CMV vaccine, which is under investigation as well. Congenital CMV is the most common non-genetic cause of permanent childhood hearing loss in the US. Just as there is no universal CMV screening guidelines in place for pregnant individuals, there's also no systematic screening guidelines in place for newborns either. And because the majority of infants with CMV are asymptomatic at birth, the true impact of congenital CMV is not well defined. The prevalence of congenital CMV is estimated to be 0.46%, with an estimated 20,000 infants infected with CCMV in the US each year. Lutz et al. Demonstrated that there are regional differences in CCMV prevalence observed in the US after adjusting for maternal race and ethnicity. As can be seen here on the map to the right, the states in light blue represent those states with the lowest estimated pooled prevalence, and the states in red represent those states with the highest estimated pooled prevalence for congenital CMV. In addition to regional differences in CCMV prevalence, prior work has also demonstrated disparities in CCMV burden among non-Hispanic Black and non-Hispanic American Indian and Alaska Native infants, likely related to socioeconomic and systemic inequities.
We'll speak next about testing options for newborns with congenital CMV infection. CMV DNA PCR has replaced prior methods for testing, which included viral culture and urine shell vial assay. But what is still up for considerable debate is which specimen type is the best for PCR testing. There are three primary options, which you see listed below. The first is urine CMV DNA PCR. This is currently the gold standard for testing. It has very high sensitivity and high specificity. However, each of these specimen types has its relative pros and cons. The relative con of urine CMV testing is if we're testing newborns in the immediate postnatal period, they have relatively low urine output those first couple of days, which makes it feasibly challenging to collect urine. The second option, which has the benefit of easier collection, is saliva CMV DNA PCR. This can be collected via an oral swab, as you see in the picture on the right. It also has high sensitivity and high specificity, but has the risk or the con of false positive results. The false positives occur from contamination of the swab with maternal or donor breast milk that is shedding CMV. If either of those samples, if the breast milk or donor breast milk has CMV, that will be detected in the saliva swab and can result in false positives. For that reason, it's recommended that the swab be collected 1 to 2 hours after the last feeding. The third method is the dried blood spot DNA PCR. This has relatively lower sensitivity, ranging from 35% to 75%, depending on the study. The benefit of dried blood spot testing that it is much more amenable to large population-based screening, since we already use dried blood spot for other congenital screening. Any test that is positive by saliva, however, should be confirmed with a urine CMV PCR, and it is really important for the diagnosis of congenital CMV that all testing be done within the first 3 weeks after birth to help distinguish between congenital infection and postnatally acquired infection. Next slide. The diagnosis of congenital CMV is both based on a diagnostic test, as we mentioned in the last slide, as well as the presence of clinical findings. And there are different distinctions between whether a patient has clinical findings or not. And what you see here is one categorization of types of congenital CMV infection in terms of their severity of presentation. The first is CMV infection. These are kids that, newborns that test positive, have laboratory evidence of infection, but they have no apparent clinical signs and they have normal hearing. The second category is congenital CMV with sensory neural hearing loss. These are the newborns that have both laboratory evidence and sensory neural hearing loss picked up on the initial newborn screen, but no other clinical signs of infection. And then the final category are those newborns that have clinically apparent signs, which we'll talk about in the next slide. They also test positive by one of the assays we mentioned previously, and their hearing loss can be variable. Next slide. These are some of the signs and symptoms of congenital CMV. However, it's important to recognize that most newborns will be asymptomatic. Roughly 90% will have no apparent external signs or symptoms of infection. It's only 10% that will be born symptomatic. These are typically newborns that acquired infection in utero during the first trimester of gestation. Some of the signs that are listed here include CNS findings, including microcephaly and imaging, intracranial calcifications, and other cortical or cerebellar malformations. Chorioretinitis is classically described as well, with more severe presentations of congenital CMV, liver and spleen abnormalities, a blueberry muffin rash as it's described, intrauterine growth restriction, thrombocytopenia, and then of course sensory neural hearing loss. Next slide. The evaluation for any newborn who is suspected of having congenital CMV should include additional studies in addition to specific testing for congenital CMV, and these are listed here. There should be laboratory testing to look for hematologic abnormalities, including liver function tests, brain imaging, usually ultrasound initially, to identify cerebral or cerebellar malformations, which can help for developmental prognostication, an eye exam to look for evidence of chorioretinitis, and then finally referral to pediatric infectious disease specialists to help determine if antiviral therapy is indicated. Next. A little bit more about sensory neural hearing loss and congenital CMV. The manifestations in sensory neural hearing loss and congenital CMV can actually be quite variable, and this depends on sort of the pathophysiology of the viral infection in the developing ear. The cochlear hair cells can be infected and damaged. There's also impacts and inflammation on other parts of the cochlea, as well as on cranial nerve 8. Because of those variable impacts, the hearing can either be unilateral or bilateral. And it's primarily the newborns who are symptomatic at birth that will go on to have sensory neural hearing loss. That's the highest risk group, with 40 to 60% of that population developing sensory neural hearing loss, compared to those that are asymptomatic at birth, where the risk is 10 to 15%. And the hearing loss can be late onset and progressive. This just emphasizes that all of these newborns need very close audiologic follow-up, both those that are identified as having early hearing loss, but also those that might be in the CMV infection category without hearing loss. They may have initial completely normal hearing, but will require very close follow-up in case they have progressive loss. Next slide. Here at Stanford Children's, this is our protocol for following the newborns that are identified as having congenital CMV but have normal initial hearing. They're followed roughly quarterly until the age of 3 years, then every 6 months until the age of 5 years, and then annually thereafter. If the newborn has an initial abnormal hearing screen, they are very quickly referred to speech therapy and hearing rehabilitation, which has been shown to improve audiologic and developmental outcomes. And then finally, cochlear implantation is considered for any patient that has severe to profound sensory neural hearing loss and deafness, as well as anyone who has unilateral sensory neural hearing loss due to congenital CMV, given high risk of progression of hearing loss in the contralateral ear. We'll move next to speaking about antiviral management. This categorization of disease severity is taken from the American Academy of Pediatrics Red Book and describes sort of 4 different manifestations or severity of congenital CMV, starting at the top with the asymptomatic newborns. Again, these are the newborns that fit that categorization of CCMV infection, but have no other outward manifestations and have normal hearing, at least initially. The second category is those newborns that are without any other clinical symptoms and just have isolated sensory neural hearing loss. And then the third category is broken up further in this diagram into those that have mildly symptomatic congenital CMV, usually 2 or few or less clinically significant clinical stigmata, such as skin findings or mild hematologic abnormalities or liver function abnormalities. And then the final category are those that have moderate to severe symptomatic congenital CMV with potentially CNS findings on imaging or abnormalities on their neurologic exam. And what this gradation of severity allows us to do is to understand sort of what are evidence-based practices to guide antiviral management strategies. So we'll go to the next slide, and this basically gives you an overview of where we have evidence to support definitive antiviral management. where we have evidence to suggest it should be made on a case-by-case basis, and what there's currently no evidence for. We'll start with the moderate to severely symptomatic newborns. The initial studies, which were published by the Collaborative Antiviral Study Group in 2003 and 2015, were the first to show that there was a benefit to audiologic outcomes as well as neurodevelopmental outcomes in the most severely impacted newborns with congenital CMV infection. The initial study looked at 6 weeks of ganciclovir, IV ganciclovir therapy versus placebo in this category of newborns, and showed, again, a significant improvement in audiologic outcomes and developmental outcomes. The second study in 2015 looked at 6 weeks of IV therapy versus 6 months of oral valganciclovir therapy, and showed that oral valganciclovir therapy was just as effective as IV therapy and had lower risks of adverse events, which can be seen with the IV ganciclovir. And those children were followed up to 2 years of age, and those improvements persisted into early childhood development. The next category of infants with congenital CMV infection are those that are mildly symptomatic or asymptomatic. And currently, there is not a lot of evidence to support treatment for these categories. There is one small study that was done in the Netherlands, which was just published last year, the CONCERT study. It was a non-randomized study and took infants with hearing loss and congenital CMV who otherwise had no clinical symptoms. They received 6 weeks of therapy with oral valganciclovir and were able to show that those that were treated had improved audiologic outcomes. There were no changes in neurodevelopmental outcomes. So for these two categories, those that are asymptomatic with isolated sensorineural hearing loss, or those that are mildly symptomatic, it really is shared decision-making with families to help them identify the benefits, the potential benefits of antiviral therapy, the limitations of antiviral therapy, and also the risks, which are listed here on the bottom left. The risks are not insignificant. About 20% of those treated with either oral or IV ganciclovir will have neutropenia. Other risks include transaminitis, anemia, and also renal insufficiency. The group for which there is really no evidence to date is that first category, those who are asymptomatic and have no hearing loss detected in the early newborn period. There is no data to support currently that antiviral treatment impacts outcomes. And again, that always has to be balanced against the risks of antiviral therapy. Hopefully there'll be more data to come for children in that category in the years to come. Next slide. So we'll move back to a case. You are an outpatient pediatric healthcare provider, and your first clinic patient is a 16-day-old newborn male who was born at term and is presenting for a weight check. The delivery and birth hospitalization were uncomplicated, but you note that the newborn has 2 failed newborn hearing screens after birth. He's been referred to audiology for further follow-up and will be seen at 1 month of age. And you recall that there's an association between CMV infection and hearing loss. The question for you to reflect on is, what is the next best course of action for this patient? Option A, nothing and wait for the visit with audiology. B, obtain laboratory studies, including a CBC and chemistry. C, call the hospital and request that CMV PCR be run on the dried blood spot that was obtained as part of the newborn screen. D, obtain CMV DNA PCR on a urine sample. Or E, refer to ENT. We'll give you 10 seconds to reflect on your response, and we'll share the correct answer in the next slide. The correct answer in this scenario is D, obtain a CMV DNA urine PCR. This is a 16-day-old newborn with 2 failed newborn hearing screens. And we have a limited window to diagnose congenital CMV infection within those first 3 weeks. The best way to make that diagnosis, given the time limitations, is to go ahead and obtain a urine sample and send it for CMV DNA PCR. Some institutions have a more readily accessible way to do dried blood spot PCR testing, but it is not yet widely available, which is why we would not recommend that option. The newborn should also be referred for further audiology screening, which will be happening in the next week. But for initial diagnosis, the urine PCR is very important.
So we'll next move on to talking about congenital CMV screening. So why screen for congenital CMV in the newborn period? As we've discussed, identifying infants with congenital CMV at birth can be challenging, as they can present with either no clinically apparent symptoms or mild symptoms at birth, and we have a very narrow window of just 21 days to diagnose them. Additionally, the number of infants affected by CCMV disabilities is greater than the number of infants affected by conditions currently included on the newborn screen, as can be seen here on the figure to the right. Benefits to screening include early identification and treatment of those infants with moderate to severe CCMV disease, and more recent evidence supports offering treatment for infants with CCMV with isolated hearing loss. Other benefits to early identification of infants with CCMV include targeted monitoring and intervention programs, which have been shown to improve outcomes. The two most common newborn screening programs for congenital CMV are universal and hearing-targeted screening. There are pros and cons to consider for each screening program, which we'll review in the next few slides. The map on the right is from the National CMV Foundation, which shows those states in aquamarine that have implemented CCMV education and or screening programs. Universal screening involves screening every baby at birth with the goal of improving identification and early treatment, and is endorsed by the American Academy of Otolaryngology Head and Neck Surgery. Minnesota was the first state to implement universal screening, with Connecticut implementing universal screening this year. Hearing-targeted screening, on the other hand, involves screening only those high-risk infants who fail the newborn hearing screen due to the association between CMV and failed hearing screen, and is endorsed by the American Academy of Pediatrics. There are currently 13 states that have implemented hearing-targeted screening programs, with Utah being the first state to do so. In our state of California, we currently do not have a state-implemented screening program. The decision to implement CCMV screening is based on the individual institution. There are several institutions locally, however, that have implemented hearing-targeted screening that we are aware of, including Stanford Children's. One of the sentinel studies that provided support for hearing-targeted screening was the CHIME study. This was a multi-center study by Fowler et al., in which approximately 100,000 infants over a 5-year period all underwent a newborn hearing screen and were all screened for congenital CMV. This first chart shows the results. Again, 100,000 infants during the study period were all tested for CCMV. Of those infants, 449 were found to be CMV positive. Of those CMV positive infants, 31 referred on the hearing screen, which resulted in a referral rate of 7%. This was compared to CMV negative infants, who had a referral rate of 0.9%. Their studies showed CMV positive infants were significantly more likely to fail their newborn hearing screen as compared to CMV negative infants. This next diagram shows the results of the newborn hearing screening for CMV positive infants, as well as the number of CMV positive infants found to have hearing loss. 443 CMV positive infants underwent a hearing screen. 35 were found to have hearing loss. Of those 35 CMV positive infants with hearing loss, 15 had actually passed the initial hearing screen. So in their study population, they found that 43% of CMV positive infants with hearing loss would have been missed with hearing-targeted screening alone, which is one of the major limitations of hearing-targeted screening. As mentioned previously, we do perform hearing-targeted screening at Stanford Children's. It was implemented in 2018 in our newborn nursery, and per our protocol involves testing any newborn in the newborn nursery who refers either unilaterally or bilaterally on the newborn hearing screen using saliva CMV PCR testing. If the saliva CMV PCR returns positive, the infant then undergoes confirmatory urine testing within 21 days. If confirmatory urine returns positive, the infant is then referred to audiology and peds infectious disease for further evaluation and management. Our metrics included the percentage of eligible infants who were screened for CCMV during the study period, as well as the number of false and true positives based on confirmatory testing. These are our results. Between December 2018 and September 2024, there are roughly 25,000 live births of infants greater than or equal to 35 weeks gestational age. During this period, 650 infants in the newborn nursery referred either unilaterally or bilaterally on the newborn hearing screen and were eligible to be tested for CMV. Of those 650 infants, 621 were tested for CMV. Of the 621 infants tested for CMV, 13 or 2% of those tested for saliva CMV PCR positive. All 13 infants underwent confirmatory urine testing within 21 days. Of those 13 infants who were tested for urine CMV PCR, 12 were negative on urine CMV PCR testing and were confirmed to be false positive, and 1 was positive on urine CMV PCR testing and confirmed to be a true positive. The 1 patient with confirmed CCMV infection was tested for a unilaterally referred newborn hearing screen. Laboratory testing, head imaging, and repeat hearing testing were all negative. In shared decision-making with the family in pediatric infectious disease, the infant was started on valganciclovir, however, was ultimately lost to follow-up, so we're unclear on the duration of therapy. But overall in our study, we showed a high adherence to hearing-targeted screening, with 96% of eligible infants tested for CMV, as well as a high rate of follow-up confirmatory testing of 100%. However, we had a high proportion of false positives, with 12 of 13 saliva CMV PCR tests confirmed to be false positives, and only 1 true positive CCMV case identified in 6 years in a patient with no clinical signs of CCMV. Our results, we hypothesize, are likely related to low CCMV prevalence in our area, as well as to the high sensitivity of saliva CMV PCR testing that may be detecting CMV in maternal breast milk that's a residual in the baby's mouth at the time of the saliva swab, as prior work has demonstrated reactivation of CMV in the postpartum period that can oftentimes occur without symptoms in the birthing person. Our findings, however, have left us with a question of how to best identify infants with CCMV in low prevalence areas. Just as a review, these are just a few of the pros and cons to consider with hearing targeted screening. The pros are that overall it is easier to implement and that it involves screening fewer babies, as it involves only screening those infants who refer on the newborn hearing screen, as opposed to universal screening, which involves screening every baby at birth. It additionally helps to identify the cause of sensorineural hearing loss, and through shared decision-making with the family, we can offer treatment. However, genetic causes should not be entirely ruled out, as they can also coexist. As mentioned, previously identifying infants early with CCMV-related hearing loss can improve neurodevelopmental outcomes through placement in targeted intervention programs. However, the majority of infants who refer on the newborn hearing screen do not have hearing loss, and infants who are screened for CCMV based on this criteria might then be screened unnecessarily for CCMV. Additionally, hearing-targeted screening misses those infants with CCMV-related late-onset hearing loss. And as we reviewed with the CHIME study, up to 43% of CMV-positive infants with hearing loss would have been missed with hearing-targeted screening alone. There is also some uncertainty about the ideal specimen type to use, as PCR testing on a dry blood spot specimen does not have as high sensitivity as urine and saliva. However, saliva can be associated with false positives, as we saw with our Stanford study, and urine can be challenging to coordinate in a newborn on the inpatient side. And then lastly, there was the recent trial that showed benefit to antiviral treatment in infants with CCMV with isolated hearing loss that Dr. Srinivas reviewed. However, recruitment into large randomized controlled trials for this population is challenging. And additionally, we do not yet have data on the long-term benefit of treatment with valganciclovir in infants with CCMV with isolated hearing loss.
The alternative approach that many institutions and some states have moved towards is universal congenital CMV screening. 2 states currently in the United States, both Minnesota and Connecticut, use universal screening. This table summarizes some of the key studies that used a universal screening approach and the outcomes of those studies. You could see that 2 of the studies were done internationally and 2 were done here in the US. Both of those were Minnesota-based studies. The focus of this table is the far right-hand column and comparing that to the column immediately to the left of that. Looking at the number of symptomatic newborns, you can see that they picked up fewer patients just based on symptoms alone. They would have picked up fewer patients just based on the presence of sensorineural hearing loss or clinical symptoms compared to the actual outcomes of the universal screening approach, which is that far right column. So universal screening does pick up far more newborns than screening based on hearing alone or the presence of clinical findings. And the prevalence, it ranges quite significantly based on the study, as you can see, from 0.3 to 0.7% based on the population. Next slide. So what are the pros and cons of universal screening? Advocates for universal screening claim that early detection and intervention will help us improve developmental outcomes for this subset of newborns that would otherwise not be detected. And it has actually been proven to be more cost effective than hearing targeted screening, with a roughly $25 cost saving per newborn compared to $12 for hearing targeted screening. The other benefit of universal screening is that it can be easily implemented into other state or national newborn screening infrastructure, such as with the dried blood spot for other congenital conditions. The cons, though, are that we might be picking up more newborns who are in that CCMV infection category, who have infection but are otherwise completely asymptomatic without sensorineural hearing loss. And a good percentage of those newborns go on to have completely normal neurodevelopment and normal hearing. And so we may be subjecting a population of newborns to additional testing and cost of testing, and also with that increasing parental worry. That also then raises concerns about the possibility of overtreatment and antiviral toxicity, particularly for those asymptomatic newborns that would have otherwise gone completely undetected. There is, of course, the cost of the infrastructure to support universal screening, and the optimal specimen for testing is unclear. Again, if we're using dried blood spots for other congenital screening, and congenital CMV could be added to that, that is one approach, but the sensitivity of that test is still suboptimal. Next slide. The World Health Organization has optimal criteria for screening test characteristics, and there have been several articles that have debated the merits of congenital screening for congenital CMV infection using a universal screening approach. And I think the jury is still out on whether congenital CMV meets the criteria as laid out here. I think there is a clear consensus that it's an important health problem. We've spoken a lot to the available testing. The sensitivity of that testing is acceptable to most. The cost is relatively affordable. However, it's really the detection of that asymptomatic category of newborns that brings the benefits of universal screening into question. It's really unclear that whether picking up infection in those newborns improves outcomes for that population. And so the debate is still ongoing, and hopefully there will be further studies in the years to come that help provide clarity about the best approach for that group of newborns. Next slide. We also think it's important to highlight parental attitudes to congenital CMV testing. This was a study published in 2011 from the 2009 Healthy Styles National Survey, which is a male survey conducted by the CDC periodically. There were 3,900 participants roughly, and they were asked questions about congenital CMV and attitudes and preferences to gauge sort of public sentiment about congenital CMV screening. A few of the questions are listed here on the left, and the ones with the red asterisks indicated that respondents felt very strongly or somewhat strongly with the statement. And those were, I would want to have my baby tested for CMV, even if my doctor or hospital didn't do it routinely. I would want to know if my child has CMV, even if he or she never develops problems, again, speaking to that asymptomatic newborn category. And some would be willing to pay out of pocket to have their child tested for CMV. So strong public sentiment in favor of CMV, but still many questions lingering about the best approach. So an audience poll after hearing the information that was presented today, based on this information, do you think congenital CMV screening should be implemented? First option, yes, universal CMV screening should be implemented. B, hearing targeted CMV screening should be implemented. C, no screening at all should be performed. Or D, unsure. And we'll have you reflect on that question, and please include any thoughts you might have in the questions towards the end. We'll conclude on the next slide and open it up for questions shortly after. So our final take-home points, we'd like you to recall that congenital CMV is the leading non-genetic cause of congenital hearing loss. Newborns with congenital CMV who are asymptomatic but have early hearing loss warrant very close follow-up and confirmatory testing within 21 days of age. The gold standard test for testing is currently a urine CMV PCR. We've discussed many of the pros and cons to hearing targeted versus universal congenital CMV screening. And we could see in the United States currently that different states have taken different approaches. But really what we need are additional studies to understand how best to manage that asymptomatic category of newborns who do not have detectable hearing loss early on. More data to inform appropriate prevention strategies, particularly in pregnancy, and also management of non-primary infections during pregnancy. Thank you so much for your time. We have included our email here if you would like to email us after with questions. We're also happy to open it up for questions now.
Thank you, both of you. Great presentation. I have a few questions. I want to ground us. I would love one of you to do a basic explanation of screening versus testing on anything.
Yes. So screening is looking at, there's two different approaches. We could look at all newborns, or we could look at those that are highest risk, but it's trying to identify children who would otherwise not present or would present at a late enough period where it would be difficult for us to intervene. So the goal of screening is to identify children who would benefit from early intervention or treatment to slow down or prevent the progression of disease. Testing is our strategy for performing screening, and we've discussed many different options for testing that would allow screening to happen, both in hearing targeted screening or using universal screening approaches.
Okay, so I'm just going to take it a step further. For those folks, we have, maybe folks who aren't in medicine technically or nursing. So I just want to remind folks that screening, something called universal screening, is something we do perhaps when those coming into labor and delivery or triage, we universally screen for substance exposure. I mean, we ask everybody. We're not choosing who to screen. They're not walking through the door and we're deciding at that moment who to screen. We universally screen versus running a toxicology test on urine is a test. That is not a screen. And so I just want to make sure everyone understands the difference between screening and testing. Can you both speak to, and it's up to you who wants to go first, but I'm fascinated by the idea of screening in pregnancy, right? And when you show a slide where a substantial part of the South of the United States has, I don't know if you want to call it high, moderate, whatever, an increased incidence of CMV, are there pilots that are in place to, whether it's you test, I guess, during pregnancy, it's not a screening. I guess you do screen too, but it's really testing. before you get to the point? Is it a money thing? Is it it's because the testing is just not as, so can you delve into that a little bit?
Sure, I can start. I think there are still many lingering questions about CMV and pregnancy, and there's been significant variation internationally in congenital CMV infection in pregnancy approaches. One of the challenges is sort of what is the optimal testing? Much of the screening testing that's done in pregnancy is sort of serology based. CMV IgM is notoriously non-specific. It cross-reacts with several other infections. And so using antibody testing for screening in and of itself has significant limitations. More specific and sensitive testing would require more invasive testing, including testing on amniotic fluid. The other question that lingers is sort of what do we do once we identify that a woman has a primary CMV infection during pregnancy? And again, there are significant limitations in what we know about the best approach to management in those scenarios. There are two treatment strategies that have been looked at, including CMV immunoglobulin, which has not shown to change or improve pregnancy outcomes or neurodevelopmental outcomes in newborns born to women with primary CMV infection. There is some limited data, particularly from Italian studies, and one recent small study showing that valganciclovir during pregnancy might improve newborn outcomes to women that have primary infection. So I think the first question is, what is the best test for screening? But really, once we identify those women, what is the data to guide how best to manage those infections in primary pregnancy? And that is still also unclear.
Thank
And
you.
I think taking it.
Go ahead.
Oh, sorry, I was going to say,
Go.
also taking it, yes, taking it from a public health perspective, I think also thinking about prevention and education, but in a culturally appropriate manner as well. So I think it's also from a system perspective as well. So how do we, because the risk factors associated with CMV infection are going to be things that we talked about, socioeconomic factors associated with CMV that increase the risk for CMV, and that goes back to larger systemic factors. And so I think from a public health perspective, not only thinking about testing, thinking about management, but also thinking about prevention and education as well, and having those efforts as well more targeted and focused towards areas that we know are higher in prevalence.
Well, you guys just did a beautiful job, both of you. Thank you so much. I want to go a step further on that because you showed there, it just, hit me in my heart when you see the rate due to, the location that it is mostly transmitted, and that's from other children in preschool. I mean, and so that's where you've talked about what are the downstream effects, and, are there other outcomes? Does CMV in pregnancy affect other systems in potentially in a fetus or in a newborn?
It can cause sort of fetal high drops. So if it's a severe infection and it's very early on in pregnancy, it can be associated with pregnancy loss. And then we've talked about sort of like the gradation of outcomes in newborns, ranging from more severely affected, particularly if it's primary infection early on in pregnancy, compared to more asymptomatic infection with non-primary infections or those that are later in pregnancy. But pregnancy loss is the other big one that we should highlight here.
Thank you for that. And we just had a talk on recurrent pregnancy loss with Dr. Lati. So it's in our mind at this moment. So thank you very much. I do have a question here for you. What is the outcome for the outcome data for treatment of asymptomatic congenital CMV?
Yeah, To my knowledge, there are actually no studies that have really looked at that asymptomatic category. Again, these are the newborns that have infection, no clinical symptoms, no hearing loss. And you can imagine that it's just difficult to really identify those newborns first and foremost. You would really need to have a universal screening approach to identify those newborns, to be able to study them. And that, I think, first and foremost, has been sort of one of the limitations of better understanding what treatment approaches are to that population. But it is a big question, and I think it is the next big question that needs to be answered to help us determine the best screening approach.
Is there a strategy for testing infants who are SGA, which is small for gestational age, for congenital CMV?
One of the things that we didn't mention during our talk was regarding expanded screening, expanded targeted screening. That's actually a newer screening approach that they are doing currently in Utah. The two most common screening approaches are going to be universal and hearing targeted. But one of the newer screening approaches that's actually very recent is expanded targeted. And the idea of expanded targeted is that not only are you testing infants who refer on the hearing screen, but you're also screening infants who show clinical signs or symptoms of congenital CMV. And one of those signs or symptoms would be SGA. And so if you follow that type of screening program, then an infant with SGA would be tested for congenital CMV. And then depending on which screening program you're using, you could use saliva, urine, or dry blood spot, depending on the type of screening program that you're implementing.
This listener noted the 6 years here at Stanford. Are you making any changes to your congenital CMV screening program?
That's a great question. We are currently in discussion about next steps. We have made a number of changes throughout our study period, including our saliva CMV PCR testing that we're using. So we changed laboratories that we were using. We were previously using a send-out lab. We changed to our Stanford in-house laboratories testing. We also extended the duration between the time that the infant fed and the time that we were obtaining the saliva swab, just to avoid the possibility of contamination with maternal breast milk. We made those two changes, but still continue to see false positives. And, so I think moving forward, we're still in discussion, whether that be thinking through whether we need to think about which population would be best to screen. Do we think about screening babies who are higher at risk? Do we think about screening babies who may be showing more signs and symptoms? So to the question about SGA or babies who might be microcephalic, but we are currently thinking through best next steps.
This just came in. You mentioned over-treating asymptomatic congenital CMV. Why would you not want to treat even those that are asymptomatic?
Yeah, that's a good question. I think it's really a question of risks versus benefits of treatment. What we know about the nucleoside analogs, the antiviral nucleoside analogs, is that they do carry significant risk. There is the risk of the hematologic abnormalities, renal function abnormalities, and risk of transaminitis. There's also sort of questions about future reproductive risk and whether the medications might potentially have teratogenicity associated with them. And so that raises questions about exposing this population of newborns to that risk and understanding what is the benefit that we're balancing that risk against. And to date, there really isn't enough data to guide what should be done with that population. So that is where we are in this journey towards management of congenital CMV infection. I think it's sort of the next frontier, the next big question that needs to be raised. Now with more institutions and states in the US, I should say, moving towards universal screening, I think that will lend itself to improved identification of those newborns and potentially studies that will then help us understand what is the best management practice. But really, right now, we don't have enough data to guide answers to that question.
Last question, just throwing it out to both of you. 15, 20 years, anything like, what do you like? Oh, I think, where is this going? Where are we going?
I think it's going to be really understanding. There's just so much heterogeneity here, right? We saw a lot of variation in prevalence across the country. We saw a lot of variation in approaches to screening. We see a lot of variation in the clinical manifestations of congenital CMV infection. And so as we learn more about this condition and its manifestations and the public health implications, I think what I'm hoping for in the next 15 to 20 years is that we're better able to appreciate the nuance that we're seeing and develop evidence-based strategies that will help us identify maybe different approaches for maybe different states, as well as different risk newborns. I think local prevalence really does need to factor into screening approach. And as Dr. Wang pointed out, I think that is why the yield at our program has been so low. But as more centers design studies, conduct studies, and generate data, both about screening approaches and management approaches, I think we'll be able to pull all of that data together to help each state, but also each family decide what is best for a given child and for populations of children.
Nicole?
I think Dr. Srinivas said it best, and I couldn't agree more with what she said. I'm also agree with everything she said, and I'm hopeful that over the next 15 to 20 years, we will get more data and that it will have wider spread public health implications that will help us in regards to how we manage CMV, how we test for CMV, and how we have the most impact for our families and for future patients who are impacted by CCMV.
We can't thank you both enough. And I feel fortunate that families, yes, probably in the San Francisco Bay Area, but hopefully nationally, are affected by the care that you both offer and the research. And just very grateful to both of you with sharing your knowledge today.
Thank you so much for having us.